So we've heard about all of these different biomarkers. We've heard about guidelines. We've heard about sort of difficult to treat versus severe, uncontrolled. What is the current place for these biologics in the guidelines? Where do they fall into sort of our realm? And you talked about sort of not this exacerbation prone. So when is it that we use these different therapeutics according to the guidelines?
Well, again, we have to take a step back. All of the currently available drugs are approved upon decrease in exacerbation. So that's the low-hanging fruit. As we said before, you pick the comorbidities that are causing the patient the most problem and what drug you think would most efficiently attack that. And then the rest is insurance coverage, phase of the moon, relative humidity that day, which way the wind's blowing, and all other important kind of determinants like that.
Right.
But I know there are no head-to-head comparison, but the patient population in different studies were different. With omalizumab, very old studies, when it first actually was studied, it was on patients on inhaled steroid, whether they were on LABA or not, didn't matter.
Just BDP, that was it.
So
Right.
it was moderate, actually moderate
Yeah,
to
it's
severe
more of a
asthma.
moderate population.
And it worked in the allergic population, reduced exacerbation, maybe not to the extent that we've seen in the MEPO data, but the MEPO studies or the anti-IL-5 studies recruited patients with 2 or more exacerbation with high blood. So it's a totally
Very
different
severe
Population,
population.
exactly,
Right.
exactly
Coming
right.
back to dupilumab data, the studies, they actually recruited moderate to severe. They only had to have 1 exacerbation. So it's probably a less severe patient population than the anti-IL-5.
Other than the oral
studies.
steroid dependent.
But
That was
still
a
showed
separate
a
study.
bigger signal for exacerbation reduction.
Right.
Yeah,
Exactly
I think
right.
you can look at sort of, I've sort of tried to figure out, is there a difference? And I think and I'm curious to know your thoughts. I sort of look at what is the background rate of exacerbations drop to in these trials, at least when you're looking at a population who is on moderate to high dose ICS LABAs, right? And I think that's where you start to see maybe there is some comparison there. I'm curious to hear your
Yeah,
thoughts
well,
on
I mean,
that.
And it clearly isn't zero. It
Right.
does not
It does
drop
not
to
drop to
No,
zero,
no, no.
absolutely.
And if it's 2 a year with a 50% reduction, well, that's 1 a year. So that's going to be hard to measure in
Right.
6 months.
Right.
But there's no question the anti-IL-5s show that the higher the exacerbation at baseline, the better effect. We've shown the similar thing with omalizumab post hoc analysis. Although we didn't have the history of exacerbation, the pivotal studies recorded, we looked at use of LABA in hospital admission the preceding year. We had that data. So it tends to be that the more severe patients, obviously they are a higher risk of exacerbation, then the reduction is
Right.
more pronounced.
One of the IL-5s just reported an enhanced, paradigm, which OCSUs, nasal polyps, FVC less than 65% use, and 3 or more exacerbations in a year all predicted an enhanced response to that anti-IL-5. So I think that's an important thing to keep in mind.
So to get back to your question, where do they fit into the guidelines? They fit in the severe end of it. When you have tried, as we've all discussed, a step up paradigm, once you've tried everything else, that's where they fit. And I think that's driven largely by economics. If there was not an economic factor, we may start parsing these out a lot earlier in the pathway. But because of economics, it's at the end. When nothing else works, when all the co-factors we spoke about, adherence and comorbidities and adverse environment or misdiagnosis have been excluded, that's when you start using them.
So this has been super informative. I have appreciated and enjoyed having this discussion with all of you. Before we end the discussion, I just want to get some final thoughts from all of you about the use of these therapies, about biomarkers, about sort of where you think we're going. Nick?
Yeah, no, it's thank you for having me, Neil, and I certainly enjoyed the discussion. But I think it's an exciting time for patients and for clinicians like us who treat severe asthma. I think we're seeing more and more opportunities. We no longer think about it as this disease that fits all. So we know how to, at least we think we know how we subdivide asthma. I think the biomarker field is expanding, more to come. Which will allow us to tailor therapy. And then that's the whole thought of precision approach, to managing asthma. We're not there yet, but we're getting there slowly. And I think the use of these biologics we have now will help a lot of patients out there. Trying to figure out which one to use is still a management dilemma. I think, in my mind, the more the merrier, and the more options we have, the better. Uh, but certainly, we like to do more work to sort of to try to decipher which one would be best for which patient. I think that's still ongoing.
Brad?
Well, I think the obvious low-hanging fruit, as we discussed already, are omalizumab for younger patients or patients with hives, IL-413, nasal polyps, and atopic dermatitis. Clearly, that's a low-hanging fruit. I think the bigger question is in the anti-IL-5 space, what predicts a more robust response? And it's clearly a higher eosinophil count in the peripheral blood compartment to begin with. I think enhanced responses, I mentioned the study that was most recently published shows us that, again, the patients who have more sustained disease activity signal tend to respond well to that. But remember, the IL-413 drug is the only drug that has OCS in their package insert too. So
Yeah.
I think it's
More to come, right?
Yeah, right. That's why we have a job.
Exactly.
Now, I actually would echo the comments of my colleagues on the table. It's been a very exciting discussion. We're going to learn a lot more about these. We're at the beginning of this journey. It's going to tell us, we're going to learn how to use them, in who to use them, when to use them. We're going to learn about the disease we think we understand. It's going to tell us more than stuff we don't understand. I think it's a really exciting time.
I think
For
it's
all of
more
us.
important to think about what we don't understand and
Right.
try to find those answers.
Exactly. Finding the questions in these solutions is definitely, I think, part of it. So thank you all for your contributions on this discussion. On behalf of our panel, we thank you for joining us. We hope you found this peer exchange discussion to be useful and informative. And with that, we'll conclude.